Good evening. I'm Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. On behalf of our General President, Brother Willis Lonzo III, I'd like to welcome you to this evening's Surgeon General Initiative webinar on colorectal cancer awareness. This actually takes me back in the vein of sharing too much. It takes me back just a touch to my first colonoscopy, and I do remember it vividly because I actually chose to stay awake. I think that poses for some interesting questions and experiences, but before we get to that, allow me to let the program proceed. And I'll begin by welcoming back as tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health. Dr. Brother Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha Phi Alpha, and he is currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. Brother Dr. Narcisse is board certified in internal medicine and in geriatric medicine, and he is a fellow of the American College of Physicians and the Society for Hospital Medicine. Brother Dr. Narcisse, have a great show. Look forward to speaking with you at the end.
Thank you, Brother Sterling. Tonight, we're going to be talking about colorectal cancer. It's the third most common cause of cancer in the U.S., second most common cause of cancer death. Cancers in the colon, and these, while the overall rates of cases and deaths seem to be declining because of our early screening programs over the last several decades, African American men and women are much more likely to get disease and more likely to die from it than other groups. So to educate us more on this topic, I'd like to bring to the podium Brother Ronald Coleman. Dr. Coleman is a fall 1984 initiate of Delta Kappa chapter at Alcorn State University and a member of Chi chapter at Meharry Medical College. Graduate of both institutions and trained as an intern resident and fellow in gastroenterology at the Baylor College of Medicine, and also completed a year of therapeutic endoscopy, which is something that most gastroenterologists are unable to do. Subsequently, has become a member of Alpha Eta Lambda chapter, my chapter in Houston, Texas, and has practiced over 20 years in the Texas Medical Center with the Diagnostic Clinic of Houston. Fabulous practice. He's been involved with specialty societies nationally as the president, was the president of the Gulf Coast GI Society, where he continues to serve on the board of directors. He served in multiple positions of leadership in several companies focused on different areas of healthcare, involved with getting people out to get more access. He has participated in his own nonprofit, Hope Through Grace, where they help obtain colon cancer screening through colonoscopy. He's also founded and funded endowed scholarships to Alcorn State and to Meharry Medical College. I'd like to bring to you my upper level resident when I was in training, Brother Ronald Coleman.
Thank you, Brother Narcisse. I do appreciate it, and I'm very glad to be able to bring this topic to you guys. I have a few slides, but as a preamble, I did learn to do a lot of therapeutic things while training, and I'm fortunate enough to have had a practice lifespan to go back to before we were able to do screening colonoscopies. In that, back at that time, colon cancer was the scourge of our practices because we knew something was wrong, but the insurance companies didn't pay for the screening procedures. Now that they're paid for, we have problems with getting people to take advantage of the access. And all those fancy things that I spoke of that I learned to do with scopes during my therapeutic training year, there's nothing more important I do now than a screening colonoscopy. As Dr. Narcisse said, colon cancer is the third most common cancer, but it's third by a long shot. It's nowhere near as common as breast cancer. It's nowhere near as common as prostate cancer, but it's the one of the leading cancer killers despite those meager numbers. What we have to do is get people educated, and then we have to get people access, which is a topic beyond the scope of this conversation. But I want to give you guys some facts. Now, it's important that you guys either screenshot or take pictures of the slides and transmit it to people who are not here, or what you could do if they have the time and energy, catch our link and let them watch us in the future. Another correction I'd like to make is it's not Alcorn, it's not Al Wright, it's Alcorn and All Right. The brothers at Delta Kappa would have my hide if I did not make that correction moving forward. All right, I'm ready for the slides. All right, so basically, we think about colon cancer as an adult disease. The screening starts at 50 for most people, and for African Americans, it's 45. And the reason it's 45 is because we as an African American, if you couldn't tell by the screen, we tend to get colon cancer at an earlier age. Colon cancers come from colon polyps, which we try to remove at the time of colonoscopies. If we can remove the colon polyp, most of the time you don't get the cancer. If we can remove the polyps before the cancer occurs, then that's where we do the most good. For African Americans, not only do we get polyps at an earlier age, we also get cancer at an earlier age subsequently. And the fact of the matter is the medicines don't work as well when we do. So our survival rate is lessened for those factors. So we try to get African Americans in at 45. Now, unfortunately, my non-African American colleagues are not as attuned to that, so they may not be as persistent at age 45, and the number 50 still floats around out there as a number for everyone. For African Americans, it is worth repeating, it is 45. We get it earlier. When we get it, it's worse for us. So if you have loved ones that are 45 and above, make sure you spread this information. Another thing that I've since I was practicing from the time before screening to now is that we have gotten more people involved, and I will probably, other than our fraternal surgeon general, I would probably say that there are several people viewing us right now who've already had your colonoscopy. Well, this is not a waste of your time, because this information from you would hit a little differently than it from me, because I am theoretically full of hype and propaganda, and I'm trying to scare people into getting a colonoscopy. That's not the truth. If you come to them with fact and they hear it from a fellow normal citizen as opposed to a medical professional, that may spur them to get the colonoscopy done. While I would be proud to perform it myself, that's not as important as the fact that it's getting done. All right, we can go to the next slide. So we've talked about the people 45 and above, and I did as for if there are people who are 75 and above, the book says if you've never had a polyp, then you can opt out. I make those decisions based on the patient. If you're in really good shape, if you're really doing well, if your health issues are in control or non-existent, I don't want you to get colon cancer in your 80s any more than I want you to get it in your 50s. So we will make that decision based on how well you're doing and the risk-benefit analysis from a colonoscopy standpoint and from your personal health standpoint. Now, interestingly, what we have seen is an increase in colon cancer in people below the age of 45. A notable person of color who had this, who suffered not only colon cancer but died from it, is our own Black Panther. Now, while I appreciate the fact that he brought attention to the disease, from our normal screening practices, we would not have caught his cancer because it came on him too young. For that, in that case, we'd have to look for symptoms, which I think we'll talk about a little bit later. But if we're talking about screening, that by definition, we have no symptoms. Chasing symptoms is a different animal. And I'll segue out of my talk right now to say that if you guys have other GI or gastroenterologic concepts you want me to address other than the screening for colon cancer, then please feel free to provide them, and we'll see if we get enough interest, we'll put another one together and do that as well. Let's go to the next slide. So what are your risk factors? If you have had a loved one who's had colon cancer, we watch you a little bit more carefully. Family history is one of the driving forces for earlier surveillance. If you have a normal, I'm going to use my air quotes, normal colonoscopy at age 45, then the book says we get 10 years if you don't have symptoms before we need to repeat another one. And that will keep you at low risk for colon cancer. Now, notice I said low risk and not no risk. The reason I say that is low risk means we keep you at a lower risk for the United States. The Western world is at a higher risk for colon cancer. There's a slew of possibilities for that. Some of it is environment. A lot of it is what we eat. I will not specifically blame fast food. Take that for what it's worth. But we're at higher risk. That takes us to lower risk. But the time from our previous colonoscopy to our next one, as you can imagine, our risk rises a little bit every year. So you have to be in mindful of family history, because what that would do is make you a higher risk category. People at a higher risk, we watch at a different interval. If you have a family history and a normal colonoscopy, we'll do it at 5 years. We won't do it in 10 years, only because there's a genetic predisposition as evidenced by a person in your family already having colon cancer. If you look at the other risk factors, these are not modifiable. So the race, it's really hard to change your race. You can fake it, but that don't make it when it comes to medicine. Same thing with gender, I guess. That's, again, a whole nother topic. Genetics, that kind of goes back to family history. But if you have a cancer history, a strong cancer history with certain cancers, we'll watch you a little bit more carefully. And under the certain diseases, you'd probably need a specialist such as myself to define them. But something like Crohn's disease, something like ulcerative colitis are definitively higher. Even people with breast cancers or what we call genetic mismatches can be at a higher risk. So we monitor them sometimes as quickly as every year or 2 years, even without finding a polyp. Let's go to the next one. Now, those things you can't modify. The things you can modify is you can modify the fact that you're over 45 and hadn't had your colonoscopy if you're African American, over 50 and hadn't had your colonoscopy if you're not. You can modify that. But the other things that are directly associated with, obesity is associated, smoking is associated, excess alcohol consumption is associated, a sedentary lifestyle, and high consumption of meats. Now, a minute on that, again, outside of the scope of this topic, humans were not designed to eat meat at every meal. Humans were probably not designed to eat meat every week or month even. We're designed to tolerate meat. We have evolved, I'm using my air quotes again, to where we're having meat with every meal, and if we're not, people are mad. Now, I grew up in Mississippi. I don't eat meat now. That's not the reason that they made me leave Mississippi, but it's almost sacrilege not to have some big hunk of dead animal on your plate at every meal. That's not the right way to go. Again, going outside of our scope, if you look at the top 10 natural killers in the United States, at least 8 of them have been directly related to animal consumption, and colon cancer is no exception. So if you're doing any of these things, then what we need to do is get you more active, cut down on your alcohol consumption, have you stop smoking, get you less obese, and change your diet. Out of all of those things I said, the closest I've come to a fist fight in my office is trying to take a pork chop out of somebody's hand. Not literal, figurative. All right, we can go to the next slide if I have any more. And if I don't, there's just me. Now, what I would say is I would like to take it to mostly questions and answers at this point. I'm going to spend a minute while we're gathering the questions, talking about the actual procedure. So there are other ways to screen for colon cancer. We can check for blood in the stool. That's extremely non-specific. You can get blood in the stool from anything from hemorrhoids to a bloody nose. And that is extremely non-specific. And only 25% of the people who actually had colon cancer in one study by the New England Journal had a positive fecal blood test. We've gotten more sophisticated since then. We now have fecal genetic tests. I use those in my practice. The gold standard is still a colonoscopy, but if you come to me and we talk about the risk-benefit ratio, and the risk-benefit ratio, the risk goes up, then we may use one of those alternative screening measures. But for the vast majority of people, the gold standard is colonoscopy, because not only can it be diagnostic, can I find a problem, it can be therapeutic, meaning I can remove the problem at the time of the exam, and I can give you a specific recommendation for you, as opposed to what we're talking about now, which is basically book knowledge. I can give you a specific recommendation and when I think you need to have your next colonoscopy. A colonoscopy is a painless procedure. One thing I do have is great drugs. You'll be high as a kite and it'll be 100% legal. There's no pain involved. Anybody who said they had pain, they didn't have a colonoscopy, or they went to the wrong MD. You should not have pain with these procedures. Once you're asleep, then we go looking around in your colon. The procedure takes maybe 20 minutes, depending if you behave, if you act up, maybe 30 minutes. And acting up is me having to remove polyps or whatnot. We don't mind finding polyps. That's actually the goal. If I find a polyp, I'm more comfortable because one, I know you're a polyp producer and I need to watch you a little more carefully. Number two, I know I've taken that polyp out, so it cannot turn into colon cancer. Now, not all polyps turn into colon cancer. Matter of fact, only 25% of them do, but we are not sophisticated enough to look at them and tell, okay, this one would turn into cancer and I can leave this one behind. So we remove them all. We send them to the pathologist. The pathologist gives us their input about not only the type of polyp and the likelihood of it becoming a malignancy later. We'll put that together with some other variables such as location in the colon, colon preparation, family history, et cetera, and we will give you your specific recommendation. That way you don't have to listen to general discussions. You can have a very specific discussion about your GI future. Now, the colonoscopy is important, but we got that covered. You show up, we'll take care of that. The day before is the most important day. That's the day we got to get you all cleaned out. Getting you cleaned out doesn't mean having a bowel movement or two. Getting you cleaned out means your colon is clean. And so when I look at it, it looks like the palm of my hand. It looks that clean. I'll take this opportunity to address one thing that's kind of a bugaboo. And since you guys can't stop me, I'll mention it. I get all kind of questions about colon cleansers. Your colon only needs to be clean when someone like me is looking at it for colon cancer prevention. It does not ever need to be clean at any other time. You were given a colon for a specific reason, to package your waste and export it to the outside environment. It does, as long as it's doing that job effectively, it does not need to be clean. The cleaning process is very important though, because if you're not clean when it's time for us to do the colonoscopy, it's going to be kind of gross for us, but it's also going to limit the amount of time I can give you before your next exam. All right. That's the generality. That's what I would give to anybody who sat down and you would ask me, all right, what is the risk of this? You mentioned risk benefit. What is the risk of this procedure? 99% of the time, there are no problems with the colonoscopy. That's why we can offer it as a screening tool. You have to think about it. Screening tools, mammograms, PSA, prostate checks, colonoscopy. Colonoscopy is not only a whole lot more expensive, it's a lot more involved when it comes to what is required from the patient, which would be you, and the physician. There's a lot more risk involved because of the sedation and the relative invasive nature of the procedure. But it is the insurance companies didn't start paying for it because it was a good idea and out of the goodness of their hearts. They started paying for it because it saved lives and saved them money from colon cancer treatment down the line. That's really the only reason we were able to get them to start paying for it. We tried for years going from a medical and compassionate standpoint. Once we start talking dollars and cents, then it made sense to everyone, and we're able to get colonoscopies basically covered within the confines of each individual's insurance. Now, as far as the individual colonoscopies following, again, you need your specific recommendation after your first one, and you have to follow that. You should get a copy of your exam. You should have discussions of the pathology, and I would hope that you would pay attention to that recommendation, because things change, people move. If you leave the biggest medical center in the world in Houston, Texas, we did your colonoscopy, and you go to Alaska to chase bear and fish for salmon, then I want you to take your colonoscopy report, find a GI doctor there when it's time, and get your colon checked, because that's the way we keep people from getting colonoscopies. We made quite the difference. From the time before, we reduced colon cancer deaths by quite a bit. All right, we reduced colon cancer deaths by quite a bit, and that is because we're getting participation. What I can say though is I don't see in my offices, in my endoscopy suite, enough people with my same skin tone. All right, I need more brown people to get screened, because again, we're at a higher risk. Everybody else is taking advantage. I want us to take advantage as well, and I think this is extraordinarily important. All right, now I think I'm ready for questions if anybody has any.
You talked about colonoscopy, and you mentioned the genetic test. Are there any other endoscopic tests, pill endoscopy that you would use for evaluation for patients?
Actually, that's not a bad idea in theory, but it's not a great idea in practice. Let me tell you why. So we use there's a pill camera. One of the things that have come along where you can swallow a pill and it tumbles through your GI tract, and as it tumbles through, it takes pictures and it gives us a better idea of what's going on the inside. There are certainly specific indications for this, and it's outstanding that this technology allows us to look into the intestines where we could not get before with endoscopes. Now, there are problems with this. Number one is the capsule just tumbles through. It doesn't, I can't stop, back up, I can't go forward. And number two, and more importantly, if I see something wrong, not only can I not get a good exam of it, if the capsule doesn't take the picture, I can't do anything about it. You have to get prepared, and you may still need a colonoscopy on the other end. There's a certain indication for that. They've been working on that science. It's not ready for prime time just yet, in my opinion. Now, I'm quite partial to colonoscopies, unabashedly stating that, but I don't think that the pill cam, if offered, takes the place of a colonoscopy.
There've been a lot of questions about why African Americans are screened less frequently now that it's paid for by most insurance companies. Are there things that you have encountered that you would like to communicate in terms of attitude or awareness or access that would encourage individuals who are at higher risk groups to get out and get screened?
Oh, certainly. And this again probably could be, this is more of a social commentary and a medical commentary that again would go beyond the scope of what we're talking about here. Access has been allowed, but not necessarily publicized until very recently. We have actually Obama to thank for a lot of that. But as far as screening goes, everybody thinks it's going to cost a lot of money, so they don't do it. That's one of the first barriers to people who don't have, they're worried about the cost, and that's legitimate. That's legitimate. You can't walk a mile in another man's shoes. You can't spend another man's money. That's a legitimate concern. So education about it being paid for is very important. Also, there are horror stories that I'll hear people right now say, hey, somebody had a whole lot of pain. That's just not true anymore. And what I've also heard is that somebody have a bad outcome. Now, while that is true, it's factually true, it's less than 1%, and that's any complication. The most tragic complication would be a reaction to medication that leads to someone's demise, or a perforation, which is a hole in your intestine that should lead to a surgery. Again, those things are the most uncommon complications, and all of them amount to 0.1% of the cases. So 1 in 1,000 will have hiccups after the procedure, which, one of the mild things. Most people will have a little bit of gas. But now when you come to our facility, we will give you a card that allows you to pass gas that whole day with no repercussions. At Bible study, library, the whole 9 yards, we'll give you a little card and you can pass all the gas you want that day. So that should not be an issue either.
Are there symptoms of colon cancer that someone should watch out for?
All right, so this one bothers me a little bit because we're talking about screening. By definition, we don't want you to have symptoms when you get to us. When you get to us and you have symptoms, we're investigating symptoms. So that goes away from the screening exam and goes into more of a diagnostic exam. Back in the olden days when people would have symptoms, the things that would get people to have a colonoscopy, would allow them to have a colonoscopy from the insurance standpoint, things like unexplained weight loss, things like a change in your bowel habits, things like blood in your stool. Abdominal pain is so vague, it's hard to imagine. But those things, you should go and see your physician immediately. This should not be a screening deal. Now, where that may come into play again, if we're going to start talking about it, is it may be important for younger people, that demographic that I told you about, that we don't have a good way to screen. It may become more important for those people to pay closer attention to any symptoms. And I have lowered the bar for our evaluation of younger people simply because you don't want to miss that. That's a devastating diagnosis for a young person. You don't want to miss it. So while I will evaluate, I will admit here, and the science will back me up, yield very, very low. A young person with belly pain, there are 1,000 things, almost literally, you would get through before you got to colon cancer as a diagnosis. Next.
One of the questions that in the chat is diverticulosis a risk factor for colon cancer?
All right, are we ready?
Diverticulosis.
No, I got you. No. Next.
So when you have the polyp, you mentioned that you do sort of a risk analysis to try to figure out when you should get the next one. One of the questions in the chat is, should you get the exam every 5 years, or is it? Can you explain a little bit about how that decision is done?
Great question, actually. So when I talked about earlier, when we're talking about our recommendations here, when we're going through these things, this is book knowledge. I'm giving you guys book knowledge. When you come and sit across from me and we get your colonoscopy done, I'm giving you specific recommendations for your specific case. That's kind of what you want. You really don't want to go in a general recommendation. The more specific your recommendation, the more specifically I can give you these ideas that you can take wherever and keep your colon cancer risk low. So if I see you here and I say, hey, we had this number of polyps, these polyps were located here, we factored in your family history, and just for instance, I say 2.5 years. What I would say is, I'm going to do it again in 2.5 years. Now, if you go to someone else and they say, hey, I look at this thing and I think maybe you can get 3 years out of it or 2 years out of it, that can't happen because there are different ways to do it. But what I don't do is take what the book says and apply it to a person. I take the person and take it to the book. So we do it a little bit different. That way your recommendation is specific for all of your factors, not because you had 3 polyps at this part of your colon, therefore it must be X, Y, or Z. Now we've gotten more sophisticated in that assessment because now our recommendations are getting more sophisticated, so that I can say, hey, you had this many polyps, they were this size, they were located in this part of your colon. So the recommendation windows can narrow so I can be most effective. Now, I'm tooting this colonoscopy horn, but the goal is not to do as many colonoscopies as I can. I mean, just because I know how, it doesn't mean I should. That can apply to a lot of things in life. But specifically for a colonoscopy, what we want to do is measure the amount of time that we can give you, maximize the amount of time we can give you between colonoscopies, because we know it is a burden, financially, time-wise, work-wise, etc. We know it's a burden. So we don't want to do too many, but I'd rather do more than less when it comes to keeping people from getting colon cancer, excuse me.
You mentioned that we weren't designed for eating as much meat as we do. Do you find that there's an advantage of eliminating meat altogether? Are the folks who've taken up the vegetarian diets, the vegan diets, the plant-based diets, is that better, or is this just a little bit is okay?
All right, there's no question from multiple health angles that a plant-based or vegan diet is better for you. There's no question. No one in medicine can argue that eating a bunch of meat is better than eating less or no meat from a health standpoint. Now, again, it's beyond the scope of this conversation, but one of the things you can do is get away from animal products to reduce your risk of colon polyps. Unfortunately, though, again, for this conversation, this discussion, we're at the point where we're talking about people of screening age. What you're trying to do is put the genie back in the bottle. You've been eating this way for 45 years. You had colon polyps. All right, what can I do, doc? What can I do? Well, you can reduce your risk for next time by doing X, Y, or Z. What you can do is erase those 45 years. What we have found, though, is that if you give your body the chance, it does a better job at repairing those errors that occur in your DNA that can lead to cancerous growth. That's not just your colon, that's everywhere. If you eliminate the distraction of animal products. And again, that's a whole nother talk in and of itself. I'd be glad to participate in it. But yes, it helps. But what it does is, if I see you and I say, you come back in 5 years, you say, doc, I'm cutting out animal products, I'll see you in 7 years, not going to work.
You mentioned that reducing alcohol is helpful. As you know, I'm from New Orleans, and it was just Mardi Gras season just recently. How much alcohol is too much alcohol when it comes to colon cancer?
All right, I'm going to be really careful in this glass house not to throw stones. But the recommendations for alcohol have not been quantified for anything but heart disease. All right, so 2 glasses of red wine are actually beneficial. Anything more than that is less beneficial. Anything less than that is not as beneficial. We've extrapolated it to other forms of alcohol. A glass of red wine is equal to an alcohol, a beer or a shot of liquor. But as far as I know, we don't have data to support. Hey, if you drink 3 glasses of red wine, you're less likely to get colon polyps. We've not. But we know that if you drink a lot, you're going to have more of a problem with colon cancer. And I'll tell you the fact of the matter is, I don't know. I need to do a study of some of my friends and colonoscopies and polyps or whatever, so I can see, if it works. Because they would have to be the control group that drink the alcohol, though. I don't have a bunch of friends that don't drink at all. We have to find that group. Next.
There's a question about Cologuard. Is that the same thing as the genetic stool test that you were talking about before?
Yeah, exactly. What that is a brand name, and there are a few out there now. But that's a brand name, and that's the one evidently that has the most money because they have the most commercials.
And you said you do use them in certain patients, but not for your routine screening.
Yeah, exactly. And again, I told you the risks are very low for most people. Now, if you start adding morbidities, for instance, if you come to my office at any age and you're between dialysis appointments, dragging your oxygen tank, short of breath, walking to the room with chest pain while we're sitting there, your risk is going to be a little bit greater because of your comorbidities. That being the case, we're going to weigh all of that. If you're completely asymptomatic, had a colonoscopy, 5 years ago without any issues, or say 10 years ago without any issues, and you are there just for screening, we may think twice about that. Or say, for instance, you've had colon polyps, you're getting on in years, and you want to know if you want to have another one. A Cologuard is reasonable in that population to see if that we could benefit you from the colonoscopy with a colonoscopy. But those, again, in my practice, I admittedly, unabashedly biased toward colonoscopies, which is gold standard. I don't use it that much. Now, other people do more, and you won't get in trouble if you had a Cologuard and it was positive and you come to see me. I'd be happy to take care of you in that route as well. But if I can offer you the best, I'm not going to offer you anything less than that.
You mentioned that physical activity is helpful. How much are you talking about? I have patients who tell me that yes, doc, I do lots of physical activity. I can walk up to the bar every night and do lifting over and over and over again. When you say physical activity, when you say exercise for prevention of colon cancer, what are we practically talking about?
Well, what we're talking about, actually, the specifics are not having a sedentary lifestyle. Now, I'm extrapolating from other data pools because I don't know of any specific studies in people who are, we know active versus inactive, couch potatoes versus active, and that activity is defined as being active 30 minutes, X number of times per day. And we see that the people who are more active are less likely to get any number of diseases, and colon cancer happens to be one of them. So it's not specific for colon cancer. For your overall health, if you're more active, it's going to be better for you, period. Even so, we want everybody to lose weight, but we know from looking at it, if you're the exact same weight as your counterpart, you sit there with a remote in your hand and doing those, like you said, 12-ounce curls, or 2 ounces if you're a liquor drinker. Let's see, is it 8 ounces for wine? I mean, 4 ounces for wine. If you do that, then we know that the person who is active is much less likely to have some of the ailments, and if they do have the ailments, they're easier to control. Now, when we talk about physical activity, straying just a little bit, it has to be dedicated physical activity. It can't be, I ran today, it was raining. I ran inside because it was raining. That's not what we're talking about. We're talking about dedicated physical activity without distraction and disruption. I walked from this store to the other store, and when I left, I had 2 bags. So that had to count as physical activity. Not really. You have to have dedicated physical activity. And what I tell my patients is, if you can have general conversation while you're quote unquote exercising, you ain't exercising hard enough. You need to pick it up a little bit.
during the pandemic, I went from the couch to the road bike, and I've been trying to exercise more. It's been a challenge, and I think when I talk to people who have busy lives, whether it's family or work or whatever, they always struggle to find ways to increase their activity, increase their exercise. Are there any specific recommendations that you give in terms of things to do? Do you prefer people to run or to walk or to bike? I heard you say that if you can talk, you're not doing enough of it. But do you have a preference?
Not really. We think if you're going to pick as an adult, now we're having grown people conversation here. As an adult, if you're going to exercise, you have to think about it. If the Olympics are not in your future, there's no use in you killing yourself or injuring yourself with exercise. I often suggest that you monitor your heart rate, make sure you're getting enough out of it. The body is extremely resilient. What you did yesterday, if you do it every day in 3 months, it won't be enough. So you'll have to pick it up. When you go to exercise and when you think about exercise, it's our evolution, I'm using my air quotes again, have made it so that we can do everything sitting down. And that has been to our downfall. Everything is too easy. I can't extract people from life, but it's all about priority. If your priority is your health, then it is on you to move that up your priority list. We don't get to watch our show because we decided to exercise. We got the kids, we have to take the soccer practice instead of sitting on our butts and playing with our phone while they're practicing soccer. And when they're young, it's horrible. How can you watch that? But anyway, what you can do is walk around the field. There are ways to make it happen if it's a priority. Everybody's going to be tired. Life gets in the way, and there will be times when you can't from circumstances. But if it's a part of your life, if it's a normal part of your life, it's a part of your normal routine, you'll miss it. And you'll make your way back to it. I don't say that everything should come secondary to exercise. I mean, that's not what we say. And in fact, since we've talked about diet and exercise in this talk, as you get older, exercise is important, but diet becomes more important because in your 20s, you can exercise your way out of a bad diet. I almost said a bad word. I'm sorry. You're out of a bad diet. You can exercise your way out of it. As you get older, the more bad stuff you put in your system, the more you will see or you will reap what you sow, not necessarily in a positive way.
Is there a role in our community in trying to increase participation in research? Do we have enough information? Do we have enough participation about what goes on? It seems like the disease behaves differently in certain communities than others. Are there things that we need to do to get people more involved in participating in clinical research?
Well, all that is specifically education. I mean, that's us talking about it amongst ourselves and getting people to participate. Now, we rightfully so, let me say that again, rightfully so, have been very skeptical of almost any institution because almost all institutions have treated us poorly over time. There's no question about that. And I can't look someone across the office in the face and tell them that I can 100% guarantee them that there's not been an episode of Black people being treated poorly in the research environment. I will say it's cleaner now, it's less likely now. The thing is, the reason the medicines we talked about that early on, the reason the medicines don't work on us as well is because they just haven't been studied on us as well. There are lots of different factors for that. Some of it is us not wanting to participate. Some of it is initially these studies not being designed to include us and barriers, even not barriers that you would say, okay, coloreds only or whites only, but the barriers that the access to the studies were basically in predominantly academic environments that Caucasians frequented. The non-majority population were taken care of sometimes by the same doctors, but in a different part of their practice that did not and were not allowed to participate in the research. And interestingly, a lot of research, I've done a fair amount of research in my day, a lot of research, there is money for the patients involved now. So some of that will be knowledge, but it would take really, it'll be a big deal for us to overcome not just stereotypical instances, overcome actual factual instances that we can review where we were not only short-shrifted in research, we were treated poorly in research.
What are the different kinds of polyps that you might find in a colonoscopy report?
Okay, that's a sophisticated question. That must be doctor related. Anyway, so there are two major types of polyps. There are probably 10 or so that would be of concern to a GI if it was a GI audience. But for these purposes, we have either cancerous or and we're just talking about polyps now, not tumors, either precancerous polyps or those that don't have any malignant potential. The majority of those will be what we call hyperplastic polyps. If you have hyperplastic polyps and there are not of a significant number and located in certain parts of the colon, that does not increase your cancer risk at all. If you've had hyperplastic polyps and there were a number of them and I didn't like the way they looked, I may shorten your surveillance from 10 years, but if you had just a few hyperplastic polyps in a benign area, you can get up to 10 years from the time of your first, the index colonoscopy to the next one, as there's no increase in cancer risk. Tubular adenomas, which is the broad group of the other type of polyps, once we take those, remove those, and the pathologist gives us the report that they're adenomas, then we look at the size, we look at the number, we look at the location. If you've had an adenoma nowadays, 5 years is a standard recommendation. If you have multiple adenomas, if it's above 3 and they're above a centimeter and all other technical stuff that we have to worry about as physicians, it may shorten. If you have specific types of adenomas, especially in specific parts of your colon, then we may come back in a year or two. Flat polyps scare us. Polyps on the right side of the ascending colon scare us. Another factoid is that the great job we've done in reducing the amount of colon cancer is predominantly by reducing cancer in the left side of the colon, which is closer to the exit. The right side, which is where the small bowel connects to the colon, we've not done as good a job over there. So I personally will spend a little bit more time looking over there because I want to make sure we don't miss anything. And that's where we can improve.
Are there any supplements that you'd recommend for colon health?
All right, so there have been some studies that would recommend maybe a diet that's high in calcium will reduce colon polyps. That's the only thing I would say that does not have any risk to it that can reduce the frequency of colon polyps. Now, this is, again, just for people who've had polyps. If you've not had polyps, the calcium may constipate you, which is not necessarily a positive thing. But what that won't do is it won't get you away from the deleterious effects of a poor diet. First thing. And second thing, if we have a colonoscopy and I say come back in 5 years, you can't say I'm going to get some calcium and I'm not going to have that colonoscopy. That's not the way that works. If we get people onto a better diet, we're going to reduce the risk of the polyps or the rate of the polyps. We're going to reduce the rate of colon cancer. And what I will say again, we're jumping out of this conversation again, as I probably have adults in the audience. The decisions you make from a dietary standpoint will go well beyond what you're eating for dinner. Most of us eat like our parents taught us to eat. We eat what we can afford and what we've always eaten. Your kids won't have the same health struggles with their diet if they are taught the proper way to eat from a young age. It will be natural to them. So it won't be such a struggle for us to try to get them to eat the right way and reduce their risk of colon cancer, which is not going to be the thing that kills most of us. Most of us are going to fall over from heart disease, which is, again, directly related to what you're putting in your system.
You spoke of the role of genetics. I find that many patients don't know their family history and don't understand their genetic risks. In the past, I've talked to people about going home on the holidays, talking to people at reunions and asking them, in addition to where they're from and who they're related to, ask about their family histories. Do you find that you're having people struggle with understanding what their own family risks look like?
It's like it's like you found all of my medical pet peeves and you're dumping them in my lap at once. All right, I don't know if this thing is going to ever end, but as long as you keep bringing this stuff up, I'm going to keep going. This is the biggest pet peeve of mine, especially when it comes to brown people. My relatives don't know what their ancestors died of. What I will hear is so-and-so just up and died. I don't know how to treat upping. We don't have medicine for upping. The more specific you can tell us, the more specificity you can bring to us when it comes to your family history, the better prepared we can be, not just for colon cancer, the better prepared we can be to help you with what could be your future, and the more tools we can give you to change your future. If your mom had diabetes, your dad had diabetes, 2 uncles on your mom's side, 3 uncles on your dad's side, and 18 of your cousins have diabetes, guess what we're going to look for when you sit down? It doesn't matter that you don't have diabetes now. It matters what we have to assess, and some of the changes that come with diabetes that put you at higher risk for heart disease, stroke, renal disease, all that happen before your sugars get high. So we can teach you what to look for. We can monitor you as if you were a diabetic or a pending diabetic. Then we can do a better job. Now, for me, I'd much rather spend time talking about preventing a problem than cleaning up the mess after the problem has occurred. And I'm sure most physicians feel the same way. We, as a people, have to sit across from our physicians and challenge them to keep us healthy, not get us healthy after we've gotten sick. Another pet peeve is you don't just go to your doctor when you're sick. If you go when you're not sick, we get to talk about all of this stuff. If you go when you got problems, I got to fix these problems. And then I got other people in the waiting room. As you can tell, I talk a lot, so I end up behind. So I don't have time to go over all this stuff that could help you and your family members going forward. So a family history is vitally important so we can do preventative measures, which is, again, encompasses this talk and others I'm sure like it.
What's the best way to find a gastroenterologist to do this risk assessment for?
You mean like me?
How do we find you?
Much, Dr. Aziz, I mean, I think you're getting a little personal.
Yes.
Well, actually, we're fairly ubiquitous now. I'm fortunate enough to live and work near the biggest medical center in the world. So there, you can throw a rock and hit a GI doctor here. It gets a little more challenging the further you get into the periphery. What I would suggest, and what I suggest to patients, even when I have to call on another specialist, if you have a primary care doctor that you know and trust, they will be the person that organizes all of your care. They probably have a GI doctor or several that they know and trust, and that way you'll have a team working together on your behalf. I would start there. If you can't, you can always Google is your friend. You can find any of us. You can put gastroenterologist, and several will pop up, and you can put near me. And instead of Taco Bell near me, you put GI doctor near me. Same thing happens.
I see Dr. Edward Levert in the chat as well. One of our colleagues from Atlanta. So it's great to see Ed and Ron together again. When you go to speak with your primary care physician or in advance of coming to the GI doctor, are there things that you would want a patient to do specifically in terms of their records or in terms of their medications or papers that you want them to have or specific information you want them to be able to answer so that you can optimize your time with them?
Yep. That's a great point. I try my best to make sure everyone has at least 1 and sometimes 2 copies of their colonoscopy report with them. If you take your colonoscopy report to another doctor to show it to them, your primary care doctor or anybody else, make sure you keep a copy, because you can tell me what you heard, but it's always trust but verify. Meaning, if you say, hey, I had a polyp, my doctor says I can go another such and such years, I'm not going to believe you until I see it with my own eyes. All right. So I need the colonoscopy to say you had polyps or no. I need to make sure you had a good preparation, vitally important. And if possible, I need to know the type of polyp so I can give you a specific recommendation. Again, there are a lot of different ways to make chicken soup. And whereas I would say 2.5 years, Dr. Levert say, no, you don't need it till 3 years. That's still a reasonable window where most of us would agree that you need to have your repeated colonoscopy. And it's easier for you to be introduced to my practice from Dr. Levert's practice if you have as much information as possible. Now, the caveat to that is if you don't have it, we can always reach out for it. The problem is, since with the advent of HIPAA, people treat medical records like they're war secrets or whatnot. You can't get it out. You have to. The law does not say we have to have, as medical professionals, the law does not say we have to have any written. All I have to do is call Dr. Levert and say, Dr. Levert, I'm taking care of this person. Dr. Levert can send me anything he has. But because of HIPAA and the fact that we're practicing defensive medicine, we have to get paperwork over there, and we have to make sure the paperwork's signed, and we have to make sure that to alleviate all that, if you have copies of your stuff, especially if you're leaving an area, get copies of your colonoscopy, get copies of your pathology, by that matter, get copies of your last hemoglobin A1C, get copies of your last PSA, get copies of your last whatever, and bring it to your next physician. We can start from go. A lot of times what will happen is, people don't, that Coleman got to know what the heck he's talking about. Let me do my own procedure. That kind of defeats the purpose. Not only does it run up the cost of healthcare, it exposes people to unnecessary risk. Even though low, there's still a risk with every procedure we do. And it gives us kind of a bad name. Whereas if you come in and we see what was done, we see where the polyps were, we can look and see the preparation, then we can give you, again, the specific recommendations for our individual practice going forward and keep you from having an unnecessary procedure, or worse, not having a procedure you need to have in a timely manner. So when we do come around, we find something untoward.
What do we do next if you find a polyp that's dangerous, or you say that the polyp has turned into cancer when it was first looked at? What should a patient do?
Okay, well, specifically, it really depends on a lot of different things, but there have been several occasions where we've cured people at colonoscopy of colon cancer, meaning they had cancer in the polyp. We took the polyp out. The pathologist says, yes, there was cancer, but the margins are clear. So you no longer have colon cancer. Depending on my confidence in whether I got it all or not, I may send you to an oncologist for an opinion. Should we offer anything else? Chemotherapy, surgery, et cetera. I may send blood work to make sure there's no increase in cancer markers in your blood. Sometimes you are cured, which leads us to another thing. We talked about family history going up. That also leads us to family history on our same genetic level, on our same generation level and down. Once you have colon cancer, then that changes the dynamics for the rest of your family. Your children are screened younger. Your siblings should get screened right away if they have not been, and we watch them every 5 years. So it's important to know the history above you. It's also important to share your present should you have polyps or cancer.
I come from a place in New Orleans where people like to talk about lots of different things, but their health history is just not one of them. And so I'm a big believer in trying to convey to people that whenever you're around your family, particularly around the older generation, try to gather up as much health information as you possibly can. That's not as much fun as a lot of other conversations, but it's a big deal. And again, if you've had colon cancers or other cancers in your family, you can really target your risk, understand your risk, and perhaps even change what's going to happen to you by doing the screening at a different time point, maybe even an earlier time point.
Agreed.
Could you just go over one more time the risk factors that you think that a person can do to change what's going to happen to them? The slide, that last slide you had.
Okay, well, I don't have control of the slides, but if you put the modifiable risk factors back up, if we can do that. So basically, off the top of my head, even without that, the things you can do, the most important thing you can do, especially as an adult, is to, next slide, is there you go, modifiable risk factors. So now if you think about them, my order was not necessarily specifically in order of importance, but what I did when I put these things down, that's back, but I wanted to say, all right, these things can help you in multiple areas. So that's why I picked these. All these things not just help colon cancer, they help you across your medical history period. All these things have been definitively linked to an increased risk for colon polyps and indeed colon cancer. But this is not a GI specific list. We don't necessarily have a GI specific list for things. Okay, well, if I do this, I'll reduce my risk for colon cancer, but it won't change my risk for, say, breast cancer or prostate cancer. That's not what this is. This is a list of things that you can do to change your risk, or at least modify it. And that's why we call it modifiable risk factors. The genetic predisposition is not taken away by these modifiable risk factors. Meaning, if most of the women in your family had breast cancer, you can't say, I'm going to eat right, I'm going to stop smoking, I'm going to stop drinking, get up, move around, and I don't have to have my mammogram. That's not the way it works. What we're trying to do is reduce your risk. And as far as the dietary component, I will tell you, and I hope you guys hear it more and more as you attend more of these seminars, it's becoming more and more painfully clear. We're doing a lot of this to ourselves.
I think that's the take-home message that I have been learning personally, professionally. Changing our lifestyles, changing our diet is going to be such an important piece of what we do. If you are interested in learning more about your risk at a personal level, and you're in the Texas Medical Center, Dr. Coleman is available. He practices in my hospital, and he's just as funny in the office as he is in the presentation, as he is on the wards. But I'd like to thank him for spending so much time with us this evening. His knowledge and his experience has been most invaluable. I'd also like to thank the audience. Can't do this without you. We're not going to go through the like and subscribe kind of thing that you see, but if you choose to watch this on YouTube and you want to like and subscribe, go ahead and do that. But this is the brainchild of our General President, Lonzer, and our Surgeon General that started the evening, Brother Sterling, Dr. Sterling. Dr. Sterling actually has a new book out that speaks to his lifestyle recommendations. And if you're interested in learning more, you can reach out to him. His book is available on Amazon under Dr. Jeffrey Sterling. I'd like to thank you, all of you, one more time, and wish you all a blessed evening. Stay safe.
All right. Thank you so much, brothers. And before we end, there was a lot of, Dr. Narcisse, can we mute your, thank you. Thank you for that. There's a lot of nuance that was given by Brother Dr. Coleman, and I want to thank you for that. It's always important. But my conversation to you is not so much about you as an individual, but the circumstances that we as a community confront. And in my closing remarks, I actually want to speak to some things without nuance so that you can move as closely as possible to what actual recommendations are. And if you approximate those, great. If you can make lifestyle changes in total, that's even better. But first of all, we just need to understand that the Black community is uniquely positioned to suffer colon cancer due to the social determinants and social influencers of health. Our consumption of an evolved post-slavery diet, higher rates of poverty, food and health deserts, and other cultural norms all predispose us for worse outcomes for colon cancer. The closer you get to a plant-based diet, the healthier you're going to be, the lower your risk of colon cancer will be, and the greater your life expectancy will be. Hard stop. One thing that you really need to appreciate, I mentioned before, an evolved post-slavery diet is pretty much what we do here. And you should be aware that this colon cancer conversation is, as was mentioned, largely a Western diet phenomenon. Africans before slavery occurred were not consumers of meat. They were farmers that largely dealt with things that they grew. And that is the formula for health. We come from a very healthy group of ancestors, and the more we approximate that and eschew fast food specifically, I think that, let me just go right into that because I don't want to equivocate on this point. The World Health Organization actually has classified processed meats, which include ham, bacon, salami, and hot dogs, as a group 1 carcinogen. That means these things are known to cause cancer. There is strong evidence that these things cause cancers. Processed meats cause cancer. Eating processed meats actually increase your risk of bowel and stomach cancer. Other red meats, such as beef, lamb, and pork, are actually classified as group 2A carcinogens, which means that they probably cause cancer. But the point is the same. The more that you're out there eating red meat and processed meat, the higher your risk is going to be for obtaining cancer, period. Now, I'm going to go deeper into that rabbit hole and just point out that even eating about 700 grams, which is a raw weight of just over 1.5 pounds of red meat a week, increases that risk for colon cancer, and that your risk of developing bowel cancer goes up 10.5 times for every pound of processed meats you eat per day. So think about that when you're eating quarter pounders, a pound of bacon for breakfast, or 3 or 4 hot dogs at that barbecue. We have to adjust our diets toward health, which will promote a higher quality of life and a better longevity of life. There's just no other way to do this. Final comment, remember, as is the case with many things, the way that bowel cancer, colon cancer occurs is predictable. It is foreseeable, and thus it is preventable. What the Surgeon General Initiative continues to be about is giving you the tools to be better stewards of your own health. It is largely up to you. Let's not begin the conversation, even with screening and early detection, which are all fine and good. But curative care is not the answer. We have to engage in health prevention and health promotion in order to truly optimally lower our risk for these diseases. As was mentioned at the outset, colon cancer is the 3rd most common cause of cancers, but it is an incredibly high cause of death because we get it earlier. We tend not to have it detected until later, which means that it has more time to do horrible things for us. Think about these things and act accordingly. Thank you so much for participating in these Surgeon General webinars. We will see you back here again in 2 weeks. Be safe, be healthy, be well. Good night.